Uh, Good morning, good afternoon, and good evening. It depends on the time of the day where you are. Welcome to the sixth webinar of the GHD MFNet. I guess in order, this is the sixth one on the impact of COVID-19 on polio eradication and other vaccine preventable disease elimination and control efforts. My name is Hiam Bashour. I'm a public health professional from Syria. I'll be moderating this webinar, and I would like just to take the opportunity, first of all, to thanks GHD MFNet for doing this series of webinar. Actually, that's becoming really very popular. So congratulations on this highly needed effort. And of course, it's a great opportunity to be with a panel actually of expertise on polio and measles, polio eradication and measles elimination in the globe, the region, as well as in the country. So it's a great opportunity. I welcome every one of you, participants, the team, and of course the panelists. Let me just highlight or remind you of the main objective of this webinar. So the objective of this webinar, as it reads, it says to highlight the impact of COVID-19 on the vaccine preventable diseases with a focus on polio eradication and other vaccine preventable disease elimination effort, and to identify what are the main challenges of immunization at the global, at the regional, as well as the country level in the context, of course, of the COVID-19, to discuss what are the appropriate strategies to revitalize and scale up the immunization program during the COVID-19 pandemic, and finally to propose what are the applicable, sustainable, and innovative solutions toward polio eradication and other elimination efforts. Now, we are
I cannot hear anybody.
In the arena of COVID, essential health services. As of yesterday, 29 million cases have occurred, with over 900,000 deaths in the globe. The World Health Organization and UNICEF have warned of an alarming decline in the number of children receiving life-saving vaccines around the world. This is due, of course, to disruption in the delivery and uptake of immunization services caused by the COVID pandemic. Those disruptions, of course, threaten achievement that's been done so far and progress that's been made. Polio eradication is an example. Measles and rubella elimination is another example. But also this disruption will affect reaching more children in the globe. It will affect, of course, the life of those children, especially in a time where we are witnessing a stalling coverage in the for the vaccination. Recent finding has come out from the WHO Pulse survey on the continuity of the essential health services, and according to the document, actually, it showed that the most frequently disrupted services among the essential health services was the routine immunization services, the outreach services, as well as the facility-based services. And we know why is this happening in many countries, of course. First of all, the lack of availability of the health worker, the lack of the vaccine due to the closure that's happening could be. It could be, of course, some fear aspects. So, for example, lack of the PPAs to conduct immunization activities. We have also the fear of the health care worker themselves, not to mention the lack of demand that's happening on behalf of the people themselves. They are maybe not willing or not able to bring their children to the healthcare facilities due to the fear of COVID. Final word, we're going to focus on the polio eradication, I guess, as per the objective of this webinar. And according to the Global Polio Eradication Initiative, we, of course, we're left with 2 remaining endemic countries, namely Afghanistan and Pakistan, and we left with a very few, of course, outbreak countries, I would say, with outbreak of the circulating vaccine derivative polio vaccine 2, polio virus 2. Now, I'm not going to take much of your time. It's really my pleasure to introduce 4 panelists. Dr. Jeffrey McFarland from CDC, and then we have Dr. Mohammed Ubaid Al-Islam from WHO EMRO. We have with us Dr. Azzetine Mohseni from a WHO SAGE member, and we also have from Sudan Dr. Mawahib Al-Jubara. So it's a pleasure to be with all of you now. Let me introduce the first speaker in more detail, and that's Dr. McFarland. Dr. McFarland is a medical epidemiologist at CDC Atlanta, Georgia. He worked as the country director, global disease detection director, influenza coordinator at CDC in 2013, and he worked as a medical officer immunization at the WHO country office in India in 2015. He worked as well as the director for influenza and animal human interface program, CDC Vietnam, and currently he is the Measles elimination team lead at the Global Immunization Division in CDC Atlanta, Georgia. Just before giving the floor to Dr. McFarland, I would like just to very kindly remind the participant about the etiquette for the Q&A. So we have all general comment under the chat, and it will be much more easier just to have the Q&A, your question under the Q&A screen if you'd like. That will make it much more easier for the presenters to have their answer directly to you and for me to summarize your questions. So I would kindly request that. And Dr. McFarland, please, you have 20 minutes from now. So thank you very much.
Thank you for that kind introduction. Let me share my screen here. Good, I have a fair amount to cover, so we'll get started right away. And again, thank you for the opportunity to speak with you this morning or this afternoon about these important issues. I just want to acknowledge the help of WHO headquarters and the global COVID-19 data and the help of the polio group at CDC led by Daniel Franken with Ahmed Kassem helping me. The outline will look at the global COVID-19 situation very briefly, talk about maintaining essential health services, then we'll look at polio, measles, and have a brief conclusion. So this is something you should all be familiar with. This is from the WHO website as of September 13th. And as you heard earlier, that COVID is everywhere, over 28 million confirmed cases, now 29, and over 900,000 deaths. This is the weekly number of cumulative cases of COVID by WHO region, again, as of September 13th. You can see the Americas has the most, but the Eastern Mediterranean has reported over 2 million confirmed cases, and this continues to increase. Here's a similar for deaths, because why does it cause us such grief? Is because this is such a serious disease. There have been over 55,000 confirmed deaths in the Eastern Mediterranean region. So these are all excess deaths, and it continues. Now, WHO on June 1st released a maintaining essential health services guidance, because this is really, COVID has interrupted these services and we have to focus on maintaining and restoring them. Again, the URL at the bottom of the slide. So maintaining health services, most of the health systems are facing these challenges of increased demand for care of people with COVID, but this is compounded by the fear, misinformation, and limitations on movement that disrupt the delivery of healthcare for all conditions. So under these circumstances, countries must focus and find ways to provide services for emergency care, for immunization, of course, which we'll talk about today, but treatment for other infectious diseases such as HIV, malaria, and tuberculosis, and even for screening and treatment for non-communicable diseases. Cannot forget them. You heard earlier about the Pulse survey. This is WHO's survey of countries to see how they're holding up among the during this COVID-19 pandemic. I'll show you a few graphs from there. So this is national essential health service packages and government funding, and this by income. So the dark blue is countries that had a national essential health service before COVID. The light blue is that these health services are being maintained and defined in a national plan. But the gray is additional money going towards them. And so what you see is that most countries had defined their essential health service package, but it's only the wealthy countries that have been able to really give extra money to this in this time of crisis. Now, what are the government policies in relation to service delivery platforms? Here we see outpatient, the gold is limited access, the red is actually suspended. So you can see for outpatient services, 61%, over half of limited access, almost 10% suspended, so 61% adversely impacted. Community-based care, over half adversely impacted. Mobile clinics, almost half adversely impacted. And we know that all of those are key to delivering vaccines. Here, the percentage of countries reporting at least partial disruption in at least 75% of services. And so what this means is that, as you can see, it's globally, a quarter of countries have reported at least 75% disruption in 75% of services. This is by income group, and you can see the impact, not surprisingly, is greatest in the lowest income countries, whereas 45% of low income countries have had this very severe adverse impact. Lower middle income countries, a third, but only 4% of high income countries. This should be of particular importance to this audience. The percentage of services at least partially disrupted by WHO region from those same 105 responses. And you can see the region that is most severely impacted is EMRO, your countries, your region. Now, the percentage of countries reporting disruptions in various services here, I want you to focus on the fourth line, routine immunizations. You can see 50% partial disruption, 10, 11% just severe disruption, so 61%. And then that's for healthcare facility based, but routine immunization outreach is even greater, right? 70% disrupted. So you can imagine this has had very adverse impact on immunization services. Now, why are these services disrupted? These are the opinions of the responding countries. The most common is just decrease in outpatient volume owing to patients not presenting. Something you might not think of, but people are afraid to go seek medical care. They don't want to go out. They don't want to get COVID. But it's also, related clinical staff deployed to COVID, lockdowns, closure of outpatient disease clinics, financial difficulties, many, many things, and they all combine to really make this a severe impact. Now, what do the countries say is our approaches for overcoming them? The most important, and the one that every country can do because it's not dependent on money, is identifying their priorities. Telemedicine, the second most common at 2/3, clearly doesn't have much of a place in delivering immunization services, but community outreach, redirection of patients, these are important for recovering immunization services. Now, there's not just routine and outreach, there's also campaigns. And this is one slide trying to summarize the experience to date. So it's for all vaccine preventable disease campaigns postponed due to COVID-19 by antigen as of September 1st. What you can see is all the countries in color have had some sort of postponement. Countries in green are the few that have had at least one VDB immunization campaign reinstated. So that's only 9 countries. The red have had ones postponed and not reinstated. That's 53 countries. The yellow, another 25 countries, have planned campaigns that will probably be postponed. So you can see this is really impacting throughout the world. And this means fewer children being immunized, larger immunity gaps, more susceptible, higher risk of disease. So let's look at polio specifically and see how this has impacted polio. So here, there's polio in the COVID-19 context. And I just want to, having a little trouble with my computer here, sorry. But this is the anticipated pandemic evolution from emergency phase to resumption phase to post-para-pandemic phase. The important issue here is that this is not a one-way track. This can go back and forth, and we anticipate seeing this bounce back and forth. So during the 3rd week of March, the GPEI issued its strategic guidance from the highest level, proposing to postpone all the activities not in line with the global guidances of physical distancing. This included the mass door-to-door vaccination campaigns. At the same time, GPEI capacities, including HR, data management, risk communication, and surveillance, were repurposed. They were still being used to support the pandemic response, ranging from the national level to the operational level. This translates to more than 31,000 staff, mostly in EMRO and AFRO countries. In addition, a planning and facility group was formed in mid-April and has come up with a work plan. Okay. Despite that, the surveillance process was continuing, but was severely impacted by COVID. Importantly, the program has put in place an automated monitoring and flagging mechanism to generate weekly and fortnightly alerts in case there is a drop in sensitivity or quality. The map you see here is a product of that system, comparing AFB cases reported in April last year to April of this year, and showing significant drop in the number of countries, especially in EMRO, CRO, and WIPRO, as well as in AFRO. These include endemic countries, some of the outbreak countries, and other non-infected high-risk countries. This drop may be due to lesser or slower reporting, lags in data, and specimen shipment in other regions. This is being looked into and discussed across the program's 3 levels on a weekly basis. More than 60 campaigns of different geographical scales have been paused in almost 30 countries since late February, early March. The vaccine supplies are already in the countries, but many could not be used yet due to this pause. Another 100 million doses were procured and could not be delivered due to the pause and due to significant air freight disruptions. Some of these vaccines will be delivered as we approach the SIA resumption. However, given the postponement of most of the bivalent OPV SIAs and AFRO to the first quarter of 2021, some of these vaccines may be reaching shelf life. That is, they may expire. Now, the global level public perception, as evidenced by media coverage and donor interactions, has changed. The current program messaging aims to build confidence in GPEI's ability to mitigate setbacks with innovation and overcoming challenges. The program also underscores the polio program's solidarity to the COVID-19 response and integration with other health initiatives, particularly efforts to support routine immunization and safely deliver polio vaccine in the COVID-19 context. A new word, a new problem is infodemic. This is the abundance, rather the overabundance of information, including rumors in the cyber and digital world, as well as in the real setting. These have significantly impacted the health behaviors, which on one hand means that the COVID-19 risk perception is taken over all or most other health risks, including polio. And there is also a higher likelihood of communities not accepting polio vaccine alone, but demanding other services that they value. The already tight financial situation in polio is getting tighter because of the COVID-19 pandemic. The program's HR, logistical, lab, and communication resources have been significantly repurposed in the places with strong polio eradication structures. And this translates into financial terms of almost tens of millions of US dollars. Two major aspects to be considered in regards to short to long-term financing planning are: number one, the ground loss due to suspension of immunization activities and possible deteriorations of the epidemiology that may potentially require stronger and wider activities in the future. And number two, consideration for safety of the vaccinators and staff who provide the vaccines, and safety in terms of PPE and ensuring preventive medicine measures. Some examples of lessons from a couple countries in Africa, from Burkina Faso, because they have done some work in the COVID-19 era. Again, strong partnerships in Burkina Faso, strong partnerships and working as one team are key. Quality pre-campaign briefings to all implementation actors are extremely important, and quality supportive supervision helps through quick mid-course corrections and maintaining accountability and partner confidence. Nothing new there, right? In Angola, again, good coordinated planning in advance ensured appropriate PPE distribution. Pre-campaign community meetings with traditional and religious leaders proved very effective in getting the message about how to provide vaccines during the COVID-19 era across. And strategy of using the same personnel for pre-campaign and community mobilization was effective. In addition, national level supervisors, vaccination team members, in the future, I think they should be screened for COVID-19 before they go out to work. Now, just this is impact on vaccine supply. I've already touched this to a certain extent, but there have been major disruptions. Delays are ongoing, and things completely outside the health sector, closing of borders, difficulty to manufacture and store. And so the impact of reduced demand is likely very high stock levels globally, with increasing perception of risk being in the OPV market due to considerable swings in demand, risks of write-off due to expirations, and increased capital costs tied to storing all this. In addition, the NOPV2 work streams are progressing, but they suffer from the challenges of COVID-19 also. So in summary, the critical functions identified to address COVID-19 are nice. I like this slide as a nice paradigm, where there's strategic guidance and coordination, and then the coordination, impact monitoring, and risk analyses, operational technical guidance, and GPEI operational planning on all three major areas of surveillance, endemic and outbreak response, and prevention SIAs. Now, the challenges, very briefly here, since most of the challenges were mentioned on the previous slides, but also want to touch upon the potential opportunities that the pandemic brings to the polio program. With variable national and subnational situations and potential back and forth transition in the COVID-19 phases, planning and fast adaptation is the greatest challenge. Surveillance gaps leading to potential drop in the program's ability to monitor the situation and epidemiology is another challenge. Making the PPEs available and effectively engaging the communities will be an uphill task as the recovery phase comes into. However, there are certain opportunities such that the program can possibly utilize to resume in a stronger manner. The 4 to 5 month interval pause provides opportunity to review program management and operations at the implementation level, plan for better quality campaigns. Likewise, the general upstream and downstream realization about the importance of vaccines can be leveraged, and also that the momentum that the ministries have gained and the commitment of the national governments to the pandemic response can possibly, hopefully, utilize to improve the program. Also, the momentum on joining hands with EI initiatives and other programs provides a potential opportunity to improve polio vaccine acceptance. Now we'll go to measles briefly. This is a map just showing, as of September 11th, measles incidence over the last 6 months, so only during the COVID pandemic. And the take-home message is that measles is everywhere all the time. It has not gone away. This is measles campaign status around the world. 41 countries may have had to postpone, or may postpone SIAs in 2020. The 5 countries in green have actually resumed, and they have covered 17 million persons. But in 36 remaining countries, there are greater than 146 million children who will have had their SIA delayed or will be delayed. And just the measles case distribution by month and WHO region, I wanted to look at this over the last couple of years real quickly. So you can see 18-19 was a massive year. 2020 has shown a decline. Why? Maybe epidemic cycle, COVID-related surveillance artifact, impact of distancing, but also just the cyclical nature of measles. So we do expect a rebound. To look at this a little more closely, the number of specimens received for measles testing by region here for the 3 years. And what strikes you immediately is that surveillance system is delivering many, many, many fewer samples to the global surveillance system for measles. Measles cases, and this is what you have is the blue and the orange are the first 6 months of 2019 compared to the first 6 months of 2020. And then the 3 months, and then the second 3 months, April to June of 2019 are gray compared to the second 3 months in yellow. And obviously the yellow is the most severely impacted by COVID. And what you see is the cyclical nature, it was going down anyway, but with COVID and the surveillance, it's really plummeted, just absolutely plummeted. So here, the measles and rubella data summary, I just wanted to show this to emphasize that you can see that specimens received in the first 6 months of 2020 are only 61,000 opposed to 173,000, so a huge drop off. But of note, the measles positive rate is 32% in 2020, 39% in 2019. So you're really getting about this very equal positive rate. So the quality of the specimens are probably the same, you're just many, many fewer. So the challenges and limitations with interpretation of measles surveillance data trends, as I touched on before, decreasing number of cases might just be due to the high number of cases 2019 and this cyclical nature and decreasing trend. Variability in results by country, and so it's difficult to interpret results by region sometimes. Most countries have had trouble meeting the surveillance quality goal of 2 cases per 100,000 during, and so it might just be that there's a general weak surveillance that predates COVID-19. Obviously, the mitigation measures, the physical distancing for COVID-19 has likely led to a decrease in measles cases. So in summary, these variety of factors that could affect decrease in measles cases, and it is difficult to determine the magnitude of the impact of COVID-19 on measles. So in conclusion, just real brief, the COVID-19 pandemic is impacting adversely all aspects of immunization programs, resulting in larger immunity gaps, more susceptible children, higher risk of outbreaks. Immunization programs are an essential health service with the highest priority to recover. It is not only part of the essential health service, it is at the very top priority of it. Recovery will take months to years, yet there are hidden opportunities to leverage more support and increase integration. Thank you very much.
Okay, thank you very much, Dr. McFarland, for this very, very comprehensive presentation. Now, may I kindly ask you to wait for the question to the end, which is the discussion, and I would kindly again ask the participant to put their question in the Q&A function for Dr. Jeffrey. Thank you very much again. As per the announcement of the webinar, Dr. Hamid Jafari, the Director of Polio Eradication at the WHO EMRO, was supposed to be with us, but unfortunately he is not able to join. So we're having his colleague, Dr. Muhammad Ubaid Al-Islam. Dr. Al-Islam, it's a pleasure to have you here for this webinar, and let me introduce Dr. Al-Islam. He is a member of the Global Surveillance Task Team, Cessation Risk Team, and NOPV2 Working Group from the Eastern Mediterranean region. He graduated from the medical school in 1987. Prior to his current position, Dr. Ubaid served in the UNHCR, where he was supporting healthcare system in Pakistan for establishing community-based primary healthcare program like acute respiratory infection and childhood degenerative disorder. In addition, he worked for malaria and leishmaniasis control in the Afghan refugees. Within the EMRO region, Dr. Ubaid Al-Islam worked as a medical officer for certification for about 2 years. Of course, Dr. Obaid Islam will be presenting on behalf of the region. Thank you very much.
Okay, Professor, can I be heard and is my screen visible?
Yes, yes, the screen is visible and your voice is ready. Thank you very much.
Okay, so thank you, Professor, and also thanks for MPNet for organizing this webinar on a very, very important issue. I would like to acknowledge some of my colleagues, especially from EPI and here in our regional office, to contribute into the slides. Actually, what I realized that after the first presentation, half of my job is done. And I hope you would excuse me when some of the slides which you have already seen, I would be either skipping or quickly passing through. And my talk is, although the topic includes the other VPDs, elimination and control programs, but it's largely focusing on polio.
We have allocated 20 minutes for your presentation, so you're welcome, Dr. Muhammad.
Okay, so this is the slide. I didn't have the latest data, but this is for 8th of September. The overall figure has been mentioned that it is over 2 million cases which we have reported. That, but we see that the COVID-19 cases of the AMRO so far, we are sharing about 7% of the global case burden, and we're the 4th highest region among the WHO regions by ranking. And all of the 22 countries continue to report cases. And countries representing largest regional case count, Iran, Pakistan, and Kingdom of Saudi Arabia together, they are contributing more than half of the cases. This slide I would skip, as I said that this has been discussed. And same, just quickly, I'm going to pass what I would like to highlight that, on the right side, you can see that there's a map which is showing the polio infrastructure, which was present in different countries. Lab, there were some countries where the lab and field staff was there, and there were some countries where only lab support was there. But wherever GPI footprints were there, they served as a frontline workers for COVID-19 pandemic response. And in addition to the other guidelines which have been mentioned by illustrious speaker before me, for the EPI also, there were guiding principles for immunization which were issued in late March, so that services should continue, but also the safety and security of the workers and as well as beneficiaries is ensured. There was also in parallel interim guidance for AFP surveillance, in which we adjusted certain field surveillance strategies. The primary focus was the safety and security of the worker, but also to ensure that despite pause in vaccination campaign, the core function of surveillance should continue as much as possible in all areas. Here, this is the slide perhaps where I would spend a bit more time. On the right side, the top map is showing, the countries which have some partially affected, stool specimen shipment and environmental surveillance shipment. And there were a few countries where initially the challenge of stool shipment, for instance, for the AFP surveillance was very badly affected. But then also in the lower portion, you can see that different kind of surveillance activities ranging from case search or active surveillance were affected. So overall, the surveillance activities were slowed down. And when we make a point in time comparison of this year with the previous year, we note that compared with 18 countries, meeting the two key surveillance indicators, that is non-polio AFP rate per 100,000 children below 15 years of age, and proportion of AFP cases having adequate specimens. We have now 13 countries which are meeting the target. This, by the way, also is showing that despite the fact that slowdown of the surveillance happened, but then interim guidance which were circulated and emphasized that wherever possible, the surveillance activities should continue, is also showing that at least a fairly good number of the countries managed to maintain functioning of surveillance system. The pause of SIAs was mentioned in our region only, in Eastern Mediterranean region. 50 million children were deprived of having at least one dose of OPV opportunity. And what has been the cost? There have been an exponential increase of CVD-PV2 cases in Pakistan, with spread to Afghanistan, which is having kind of an explosive outbreak of CVD-PV2 now. Also, there has been international spread from Afro to one of our member states, and I'm glad that the EPI manager of Sudan is there, and she would give more details. So Sudan has received importation of CVD-PV2 from neighboring Chad. And also, despite all those efforts for surveillance, as Dr. Jeffrey mentioned, that not only there were challenges in reporting of AFP cases, specimen shipment, but also the lab staff was repurposed. So there have been delay in detection of these two outbreaks from Sudan and Yemen, although both countries have their own challenges. In Yemen, the most challenging thing is to get specimen out of Yemen with the closure of outbreak and closure of the airport and so many other challenges through the land, shipment. So in a nutshell, the both outbreaks were delayed, and similar kind of an observation has been made in some other Afro countries. And there has been still, despite our all efforts to ensure the PPE provision or the things, there has been a cost also that, 224 polio eradication personnel working mostly at the operational level tested positive for SARS-CoV-2. So they were suffering on COVID-19. One of them in southern Afghanistan is still hospitalized seriously. And we had to mourn deaths of our two colleagues, one each from Somalia and Pakistan. This slide, I think it has been mentioned. So what I would just highlight that, both EPI services were affected, and not only these services were affected, as Dr. Jeffrey has highlighted, that amidst this challenge of polio to the polio program about the funding issues, there are few vaccines which may be reaching the shelf life and they may be wasted. This is again, I would skip. This is a scheme, in another way. We have mentioned that there was an emergency phase, which was for the period between March to June. And then we are right now, since June, in resumption phase. And there are different activities that we have been carrying out around this thing. For instance, preparation of the guidelines for conducting polio vaccination campaign, and then testing it in very limited scale. And in fact, first polio vaccination campaign under this guidance was conducted, professor in Syria, in a very small scale. But later on, this whole experience was utilized in large scale campaign in Pakistan, Afghanistan, and Somalia is going to conduct a very fairly large SNID in the next week or so. And then, during this whole period, we conducted technical advisory group meeting for Pakistan and Afghanistan to get advice how to resume polio vaccination campaign, and, balancing between whether to keep pause of the SIAs versus start of the campaign, but with some, care about workers and some special guidelines. So there is a clear plan, even similarly for surveillance, also restoration of surveillance, expansion of environmental surveillance in epidemiologically important areas. So this is the overall scheme under which we are working now for resumption of sort of pre-COVID scale of polio eradication activities. And this is just another illustration that following the tag of Pakistan and Afghanistan, developing of the guidelines, having some confidence of programs' ability to do vaccination campaigns. Now there is a good, clear vaccination schedule for Pakistan and Afghanistan. They have already conducted campaigns in July, and then both Pakistan and Afghanistan implemented a synchronized campaign in August. And they're going to have again in September a campaign followed by a campaign in October and December. And this monovalent type 2 vaccination campaign I have already mentioned. But here what I would like to highlight that among this effort in which 1.2 million children were targeted in Afghanistan and over 700,000 in Pakistan. So during the intra-campaign monitoring, few things were specially focused in the context of COVID-19, and the monitoring data has suggested that 93% of the frontline workers were using masks, which were provided by the program. By the way, this is an additional cost to the program, but sure, we have to ensure safety and security of our frontline workers who actually are the real polio warriors. And then 65% were not touching the child during the vaccination. And similarly in Afghanistan, good feedback came in from the community level. Just touching quickly now, I have shared some update what we have tried to do this thing, do the situation surveillance and vaccination activities in the given situation. But right now we are facing two distinct outbreaks. For Sudan, our colleague from Sudan will mention, but I wish to highlight that globally, if you see the map and focus on the green dots, all the green dots are CVDPV2 cases. So not only in Pakistan and Afghanistan we are having, but in Africa there is an expanding CVDPV2 outbreak, and much of this has been due to also pause in vaccination campaign following COVID-19. In Yemen, we have CVDPV1, which is a bit distinct from Sudan, that it is in Yemen, it is due to a new emergence, basically because of massive vaccination campaign, where currently all the cases are from the same governorate, Sada, where no house-to-house vaccination have been implemented for quite some time. More than half of the children have received no OPV doses per AFP data. And this is the overall situation of our region, Eastern Mediterranean region. That's how we are categorizing based on ongoing risk assessment of surveillance, vaccination campaign, management, security situations. Multiple indicators are used for doing risk assessment. And if you can see that not only Pakistan and Afghanistan, which are endemic countries, we have yellow now 4 countries, Sudan, Yemen, Somalia, and Syria, although Syria doesn't have no transmission, but when the outbreak was closed in late 2018, we felt that still this need to be monitored and provided due support. But a year ago, Sudan and Somalia were not yellow. They were ranked with Iraq and Libya and Djibouti as high risk. So now they are categorized as outbreak countries. So overall in our region, we have wild polio virus type 1 endemic circulation in Afghanistan and Pakistan, CVDPV2 outbreaks in Afghanistan, Pakistan, Somalia, and Sudan, and CVDPV1 outbreak in Yemen. So what are our regional priorities for remaining 2021? One thing program is very, very cognizant of the fact that we have to coexist with COVID-19. It is a reality, as Dr. Jeffrey mentioned, it is not going to go so quickly. So we have to develop all the program strategies in this context. So our immediate priority is rapid cessation of CVDPV outbreak, and getting Afghanistan and Pakistan programs back on the track, In Afghanistan, our major challenge is still ban on the vaccination campaign in southern region of Afghanistan, where the epidemiological data complemented by genetic analysis confirms that Afghanistan has been able to, interrupt their endemic transmission on a couple of times. And then in Pakistan, where we have quality issues, program management issues, we are going through a very extensive transformation of the program, based on the principle of fit for purpose. We're also focusing on quality issues and management issues. And of course, for surveillance, we have specific activities and program going on based on the individual countries' gap observed, issues observed, and then making country-specific plan. And the other regular program strategies or focuses, protecting all countries against importation and outbreaks through contributing into the efforts for strengthening routine immunization and polio outbreak simulation exercises. As has been mentioned by Dr. Jeffrey, that this whole COVID-19 has also educated us how when there is a sufficient political buy-in and the willingness of the program, different programs and in fact total government engagement can be assured for a public health emergency. So based on that learning, we are also doing some advocacy as well as following this principle of integration and transition. A lot of work is being done. Even a very high level committee has been formed at the regional office, and which is very actively working. And of course, certification and containment. And this is my last slide again, but the message is, we know that there is a lot of panic around second peak, which was inevitable, and but still we need to maintain public health and social measures to prevent COVID-19 infection, disease, and at the same time, we have to continue our efforts for vaccination programs. So over to you, Professor.
Okay, thank you. Thank you very much, Dr. Muhammad Ubaid. That was again very informative. Thanks a lot. There are few questions actually waiting for yourself, but again, we'll keep them to the end. So thanks again. It's my pleasure now to introduce the third presenter, Dr. Azzuddin Mohseni. Dr. Mohseni is a public health expert and a member of SAGE. He is a medical doctor and a specialist in public health and epidemiology. He has over 26 years of experience with vaccines and immunization at both national and international level. Dr. Mohseni served for 8 years as National EPI Manager at the Ministry of Health, Tunisia. And he's then moved to WHO Eastern Mediterranean Office, where he served for 16 years in several high-level positions. Dr. Mohseni, it's a pleasure to introduce you. Please, your perspective. Thank you very much. You have 10 minutes, if I may. Dr. Mohseni, we cannot hear you. Can you kindly unmute yourself?
Is it okay now?
Yeah, thank you very much.
Okay, so thank you very much, Professor Hayam. I would like also to thank all the colleagues from JSDM for taking this initiative and for giving me the floor to reflect a little bit on this important problem that is, the disruption of this very important preventive tool that is immunization. So in fact, I have prepared the presentation, but as it was said actually by my dear colleague, Dr. Ubaid, I will need to skip some of the slides and have to keep it shorter. Just to perhaps to reflect more, I'm not going to go through the situation in the region that was presented to SAGE. I am as well, not to SAGE, to TAG. I'm also a member of the Regional Technical Advisory Group on immunization of WHO EMRU. And actually, we had a meeting in April, and the office called for a meeting just to debate about the situation of the EPI and the vaccine preventable disease situation during the COVID at the beginning, I would say, of the pandemic. And the TAG has reacted with some recommendation. I also planned to talk a little bit about some information at global level, but I think it was already done. So I will just skip this to maybe to reflect some of the comments on my colleagues' intervention and on the situation, rather than go to the through the whole presentation. So. Okay, so in brief, I mean, the TAG was briefed in April about the situation in the region. Not going to bring anything new. I think it was already said by the two colleagues. I mean, actually, routine immunization is has been or was, and even has been actually the most affected component of the EPA program in both fixed facilities and outreach, mostly outreach more than the fixed facilities. And my two colleagues talked a lot about the reason for that. I mean, we understand very well why this has been affected. Again, as all the intensification and the catch-up activities, in addition to the polio and the measles, had the same issue. I mean, all the other activities, I mean, you know, there was also it was also an important barrier to continue all this support, direct support to the countries, field visits, field monitoring, in addition to the affecting the vaccine availability and the campaigns. I go very surveillance. Yes, in fact, this what is reported by EMRU is that there has been clear impact on the investigation, on the notification of the cases, particularly in measles, and maybe this is what Dr. Jeff has highlighted in terms of reduction of measles cases. Yes, there were several outbreaks last year, but also I assume that the notification rate, I mean, also was affected and had affected. So what in fact SAGE recommended, or the conclusion of the, not SAGE, of the TAG, in fact. So the TAG first requested WHO to guide and support countries to minimize as much as possible and as soon as possible the impact of the COVID-19 pandemic on immunization. Why I'm saying as soon as possible, because one of the comments is that now, so far, I mean, since we started to notice this disruption and this very negative impact on immunization, we have had several meetings, several webinars, several forum where we still discuss the reason and the causes, and we know this. So what we need now is to do our best, all the partners. This is a call for all the partners, including the countries and the partners, to move ahead and to search solution. I think the reason, both Dr. Jeff and Dr. Rabi talked a lot about the reasons. Let me just open I am back to my country, Tunisia, after 20 years of work outside of the country, and I am working on the field in the south of the country. And I was surprised to see that what happened, in fact, is that after the opening, we started to see in several countries, including in Tunisia, things. I mean, the catch-up started to work, and people started to go back, and services offered, and they started to catch up defaulters. Then the second wave after the opening, so the second wave came, and now everything is again. I mean, clear refusal from the population to get back their kids to their facilities. Now we are is the school entry season now in Tunisia, and even a lot of huge debate actually, and the refusal from the partners to take their kids even to the schools. So again, this fear is again there, and I don't think that all these recommendation guidelines that were done actually and were there will be enough. So a lot has to be done now to try to find the right strategy to get back the confidence between the public health facilities and the population and the trust. One of the reasons is that, and I'm seeing this in several countries now, is that when it comes to protecting the healthcare and improving the confidence in the healthcare through better healthcare workers through better confidence, I think most of the countries are making priorities. And the priority for this protection goes usually for the hospital issues and for the care. And public health, primary health care centers are usually the last ones in the priority. So, and for that, for example, there has been and there are demonstrations in some countries like Tunisia of these people, of these healthcare workers refusing to open, to go back to their work and to get in touch with the population. So this is a bracket just to say that we need action as soon as possible. We need action not only through a better advocacy, and I would say targeted advocacy with the decision maker at county level and the population and the healthcare worker, but also with the partners as well. Even you know, it's very easy that we can get back the polio because there is a lot of commitment and a lot of issues around polio, and maybe measles as well, but not about the routine. So what to do especially to get the routine back? And the routine is the backbone of all the vaccine preventable disease accelerated control initiative. So the tag, back to the tag. So the tag, in addition to recommending to WHO to guide and support as soon as possible the countries, the tag stresses the importance of promoting WHO guidance principles for immunization activities during the COVID pandemic. So making sure that the countries are aware, and I don't know how much the region or the RI tag or the region worked actually with the countries to make sure that they have the required guidance to get back as soon as possible their services and to plan for the catch-up. Then the tag recommended to the countries of the region to document the impact of the COVID pandemic on national immunization programs, to monitor the vaccine availability, and in particular to ensure that records are kept for children who have missed vaccination during the pandemic. Now I'm seeing on the field that there are records. However, now with the I would say this second wave and the risk that we are going to stay with this situation of COVID for a long time, I mean, accumulation of susceptibles will become a real problem in the countries. And if the country do not really track and record this, they might forget about them and drop them even from their next plans, which will actually be a very important setback to all the vaccine preventable disease accelerated control programs like polio and measles, etc. The other recommendation is that all countries should make plans for catch-up vaccination for missing children, use an appropriate strategies as soon as possible when the COVID pandemic situation allows. Countries of the region should involve the NI tag as well as the relevant partners and stakeholders in decision making on the implementation of immunization activities during the COVID pandemic and in planning for catch-up vaccination campaign of missing children as soon as possible. And the tag recommended as well that countries of the region should design appropriate strategies for the integrated delivery of essential services. So it's not only EPI, but as usual, EPI is the locomotive for other services. So better also to think about integrating and providing all a couple of other basic healthcare basic services during this period also. So in the context of the COVID and the possible reduction of routine vaccination coverage, delayed implementation of preventive vaccination campaigns and potential increase in incidence of VPDs. So we expect to have more disease rather than less. So countries of the region should maintain high quality VPD surveillance and alert function. I don't think that this has been maintained, and as we have seen actually through the presentation of Jeff and Orbit, I think several gaps actually. The surveillance system of the VPDs has also suffered and is suffering as well, in particular the lab issue and the investigation. WHO, the other issue is that how WHO can use this opportunity actually, because the region also is suffering from, even before the COVID, from stagnating coverage with around 80%. And as you know, when we stagnate, we are missing more and more children because of the natality. So how can we use actually the COVID momentum and momentum of the population and the decision maker for the vaccine? All of them, they are waiting for the vaccine against COVID. So how can we use this also to promote for other vaccines of the routine immunization program? I will stop there. I think, because the rest has been said. I will come back if I will have any comment to make. Thank you very much.
Thank you very much, Dr. Mohseni, for this. Again, it was very comprehensive. Thanks a lot. Now, the fourth presenter actually is going to be half on country level. That would be Dr. Mawahib Jubara. Dr. Mawahib Jubara from Sudan, and Dr. Mawahib is a public health specialist holding a medical doctorate in community. She is the National EPI Manager in Sudan and Associate Professor at Nile University with focus on epidemiology, biostat, research methodology, and medical ethics. Dr. Mawahib has a 9-year experience in immunization, in VPD, surveillance, outbreak investigation and response, vaccine management, and she has an extensive contribution to EPI-related research at national and subnational during the period and thesis supervision. So, Dr. Mawahib, we look forward to hearing from you on the perspective of a nation like Sudan, please.
Okay. Hello, everyone. Yeah, thank you, Infinite, for organizing this important webinar to reflect the impact of the COVID in immunizations. I am going to talk about the Sudan situations and the impact of the COVID-19 in the VPDs in general, and specific in polio eradications, measles, and Rubella eliminations, and other. Okay. Yeah. Regarding the outline of presentation, it is a small introduction about the country situation, country profile, COVID situation up to early September, impact of the COVID in routine immunization and the polio eradications, and a risk of CVPDs outbreaks, and impact of in measles, Rubella elimination, other VPD situation, action taken, and hopefully we have some successful stories. Sudan is facing many problems, and now the traditional government is recently declared economic emergencies. We have this security issue and inaccessibility for some of the district or localities, and we have economic situation and crisis, inflation, and devaluation of the SDGs. For this year, we have this heavy rainy seasons of the flood of unprecedented situation for the last 10 years. In the history of Sudan, fuel shortage. All this conflict aggravates the impact of the COVID-19 on immunization. Regarding the country profile, we have, as I said, 3 inaccessible localities, and we have a total population of 47.9, and the under 5 is 8.6. We have some special groups in terms of nomads, refugees, and IDPs represented about 2.3 million. Structure of the country, we have 18 states, 189 localities, 3 of them are inaccessible, 442 admin units. In immunization, we have 883 sentinel sites and 7,320 vaccination sites with a different type of strategy, fixed, outreach, and mobile. COVID situation up to the early of September, total number of 13,189 cases and cumulative deaths of 826, representative case fatality for 6.2. And as we see in the bottom of the graph, the confirmed cases with the case fatality, we have many peaks, mainly in the beginning of the outbreaks. Regarding the impact of COVID on routine immunization, most of immunization sites were closed during the first 2 months of the pandemic. But fortunately, the activity of both routine and supplementary were restarted using PPEs. And still we have facing the problem of continuity or provision of the PPEs for the whole country to be constant for the immunizations activities. Also, the lockdown was accompanied by closure of the PHC, as said Dr. Mohseni. PHC services in such epidemic will be not the top priority in the health. With the increase of spread of COVID-19, lockdown extend to most of the states. In terms of implementation of implementation of the routine immunization, we can see first case in Sudan were in March, and the fluctuation of provision of the PPEs affected the implementation of the sessions. And commonly, whenever we have problem, maybe in budget, the most practice that the fixed sites is remaining open for at all situations because they are the less cost. But during COVID-19, because of the availability of the PPEs for the first time in Sudan, in May to have 60% just implementation of the fixed sites, and this is mainly because of the lockdown of the health facilities. Regarding polio eradications, the last endemic polio virus of Sudan was reported in April 2001 in Pantio in all Sudan. And the country remained free until the first importation of the wild polio in 2004, and it has caused large epidemic up to 158 cases and was contained successfully just in 1 year. 2007, an imported case of wild polio type 2 was reported to south of in South Darfur with no secondary cases. The same scenario is repeated in 2008. Fortunately enough, there was no infection with no secondary cases in the country, and the last reported cases were in February 2009. 5 cases wild polio type 1 were imported from South Sudan, and it caused just 1 case in Khartoum. Regarding the population immunity for polio viruses in general, we can see the annualized coverage of OPV3, and we have a very low coverage, and this is mainly because of COVID and non-COVID other economic situation, but COVID affect mainly in the implementation of the sessions and reduce the coverage. IPV also, we have reduction, and as posts are having in the same sessions, they are the similar coverage. One of the major impact of effective of COVID on immunization, mainly in the polio program, because of COVID, the implementation of catch-up IPV mass vaccination campaign for the Measles cohort was delayed. It was planned to be conducted in early March this year, but because of the COVID, this catch-up campaign was delayed. Now we are doing our best to implement the catch-up campaign because the country entered the situation of the type 2 circulating vaccine-derived polio outbreak. Also, due to the lockdown, the AFB samples were kept in the state. This had negative impact on the type of receiving to the National Public Lab, and the National Public Lab itself was occupied by the COVID-19 lab services from April up to June. After all, if we look at the of the AFB surveillance indicators, we can see that although the process of the surveillance program was affected, but up to now we have these 320 reported cases. Unfortunately, we end with the outbreak and circulating VPDs type 2. But in general, the adequacy stool is good, 95, and the annualized non-polio non-AV rate is 2.5, with a variation between the states. Even the environmental surveillance, it is functioning during the COVID pandemic period, but the same problem of delaying in testing of the samples occurs for the surveillance, for the environmental surveillance. After all, we end and after 11 years free of polio, Sudan had circulating VPDs type 2 outbreak declared this August. The index of the CVPDs2 case was reported from South Darfur State with the date of onset of the 7th of March, but unfortunately, the date of confirmation of the case was in August. That's why we're talking about 4-month delay in detection of the outbreak, and this result late detection and circulation of the virus. Up to the last epidemic, last week, epidemiological weeks, we have these 18 circulating VPDs reported cases, addition to 4 contacts from Khartoum, Blue Nile, and 2 from South Darfur, and we have 6 positive environmental samples. An increased risk of polio outbreaks during COVID, mainly I said, as I said before, the delay, about 4 months because of the COVID-19 and the problem of the shipping of the samples to the regional lab. And such delay did not exist, as I said, in the previous 4 importations occurred in the country. Regarding measles and rubella elimination, low reporting rate due to reduction in the sentinel sites because of lockdown. We have suspension of some type of the sample because of high risk of COVID transmission, such as throat swab and oral fluid. In the absence of the BBEs, the guidelines that to stop such a sample, delays in transportation of the samples, delay testing because the personnel were involved also in COVID testing, and delay mainly, on the other hand, the proposal of the Measles rubella vaccine introduction into routine immunization. It should be submitted by this September, but now delayed up to January 2021, and also the proposal for the MR mass vaccination campaign. All this will contribute to problem in the immunity of the population, in addition to the low coverage of the post-antigen Measles 1 and Measles 2. As overall, the indicators, the major Measles surveillance indicator regarding the non-Measles, non-rubella rate, we are talking about 1 and the target is 2, there is decrease. And the COVID mainly affects the last two indicators sample received within 5 days of collection. Before the COVID, it used to be 90. Now we are talking about 77 and 78 for the result reported part within 4 days. And major Measles surveillance indicator or elimination, the annualized Measles incidence. When for the elimination, we are talking about 0. Now we have this 10.8, and the coverage of the Measles 1, the target is 95%. We have only 68% reaching this of the state reaching this coverage, and only 53 for the measles 2, and none of the state reaching for the measles 2 above 95, and for the localities we have this 14 out of 186, and one for measles 2 just representing 5%. Other VPDs, the suspension of collection affecting other surveillance.
I'm sorry to interrupt you, Dr. I'm sorry, Dr. Mawahib, to interrupt you. Actually, we still need some time for discussion, and you exceeded your time. So please, can you just be quick? Thank you.
Okay. Yes. Also, other VPDs it affected the yellow fever. Mass vaccination follow-up campaign is delayed, and the introduction of yellow fever into the routine also delayed for the next years. Action taken: planned of outbreak response mass vaccination campaign and acceleration routine immunization campaign, basing on the analysis and submission for proposal for strengthening routine immunization for Gavi and implementing for when IBV. We are starting this this month, and for outbreak response campaign. Also, development of guidelines for VPDs during COVID and resource mobilization for continuous VPDs and enhancement of the surveillance. The lesson learned: continuing API activities during other health emergencies with consideration of appropriate IBC measures, communication and improvement department and demand, and health worker motivation and retention. Finally, we have this for me as a very successful story in terms of just this picture. To have the EPI locality operation surveillance officer for case investigation in Jazeera states. This is a picture reflecting how with this flood people are going to conduct the mobile services, and this is for close area with collaboration and coordination. We reach them as outbreak response, and with this flood, this is the supply for routine acceleration campaign to reach the Red Sea states. And this in the South Kordofan states conducting outreach. And other lessons learned, we do orientation whenever we have these BBEs, we are providing for the training. On the other hand, we do it in the open area as impact of the COVID. And as I said, the BBEs for all sessions, and picture from the field makes the responsibility and accountability for the high level is very huge. Thank you.
Thank you so much, Dr. Mawahib, and congratulations on all this good work that you're doing. Thanks a lot. Dr. Mawahib, there was a question in the QA session specifically from Dr. Faris with regard to the high coverage of routine immunization in Sudan. Yet again, you reported on the outbreaks, so if you can handle that. The Q&A function or the window was really very active, and I would like to thank very much all the panelists for being so active in answering the question. So thank you very much. We have really 12 minutes before the end of this webinar. So I would like just to take a question that I myself have prepared for maybe longer time for discussion, which is the issue of this this infodemic that's really being brought up by all the panelists, being a real challenge in the COVID arena. So I'm not sure if Dr. McFarland or Dr. Obaid would like to handle that as to what really would be how to handle this attitude coming really toward rejection of the vaccine, as well as this misinfodemic that's really affecting polio and other vaccine as well. So this is one thing, and I would personally like just to bring more attention to what Dr. McFarland has presented. From your perspective and perspective of Dr. Obaid and maybe Dr. Mohseni, why the EMRO region specifically was badly affected? It was the most disrupted among the other regions. So what would be really your vision as towards the reason for that. There was some specific question from Libya, Afghanistan. I think Dr. Ubay, thank you very much because you handled all this. Dr. McFarland, your perspective. Thank you.
Okay, thank you very much. And yeah, thank you for all the presentations, extraordinarily interesting and informative. The infodemic, I am not an expert on communications. If there is somebody who is, maybe they can address it more directly. But I think what it is I know WHO headquarters, I know US CDC have created fairly large teams of communication experts to deal with this. And I know they had a webinar in Geneva when I was there in April, May. They got over 11,000 people to call in. And I think this is a recognition that in this age of the internet and people being able to post any information they want and share it, that communications is more important than ever. And without reliable, consistent, understandable information coming out on a regular basis from reliable sources like ministries, without that effective type of communication, this misinformation, this infodemic, has the potential to be very destructive, not just to immunization programs, but to all health programs. I think it's incumbent upon all of us to recognize that, to understand that organizations are taking it seriously. I don't know what EMRO is doing, of course, but perhaps there's a communication expert on the panel who can talk more specifically to that, how you achieve that. I recognize it as a problem, and I'm very pleased that that WHO and CDC and others are getting the experts together to address it. Thank you.
Okay, thank you very much. Dr. Ubay?
So I'm no different from Dr. Jeffrey. Surveillance and epidemiology is my area. But as a part of the program, I can assure you that there is a specific group who deals with this thing. On one side, how to really handle social media, electronic media, and also how to build trust and confidence of the communities. So polio program itself is also, in Pakistan, there's a misperception about the program and also a misconception about vaccine. So all these things are being addressed. You have asked why EMRO has badly affected. Can I go to that?
Please. Thank you.
I think we should recognize that majority of our countries and where large populations are living, we're having different kind of crises. And in the two countries which have recent most outbreak, Sudan is a geographical challenge, but floods, multiple communicable disease control program, disease outbreaks, political instability, if I may have a liberty to say. So all these, the rapid turnover of the leadership in Sudan has been a phenomena in the last 1 year or so. Yemen is no exception. And when Yemen, when we have all 15 paralyzed children due to a completely preventable cause in a single governorate, which is known to be having very super problem. So I think we have multiple countries where we have multiple emergencies. I think currently I'm forgetting the exact figure, but very large number of countries in EMRO are having different kind of emergencies. May I just take, I would request organizer for two things. One, in future, as Dr. Jeffrey has mentioned, for any communicable disease control program, I think, especially for vaccination, take a communication expert as in the panel. And second is, if I could get copy of all these questions, some of those I have tried to answer. And there's one specific question which I wish to answer, if you allow, Professor.
Please.
And that is for, I'm grateful for my great friend, Professor Faris Lami. For surveillance, yes, I think if there should be no misleading by when I said that large number of countries are meeting the surveillance indicators. But when we are doing risk assessment, and the risk is overall risk assessment output, you said, so we are going for subnational surveillance indicators at district and provincial level, depending upon the size of population. And it is very, very critical for all the colleagues who are listening that, you know, in polio, we say the devils lie in details and at the grassroots level. So when we are doing program assessment, we are going for subnational risk assessment, and we are finding some challenges either for polio disease or surveillance performance in certain, you know, high risk areas or sometimes populations. So I stop here, and I have noted 4 or 5 questions, but I may have not taken all the questions. So I would appreciate receiving copy of all these questions, and person who has asked his or her email, I would love to respond. Over to you, Professor, just considering the time, I'm not continuing.
Thank you so much. Thank you so much. Yes, you've been very active answering all this. So thanks a lot. And I'm sure that the organizer will handle this. Dr. Mohseni, just one quick question really with regard to what are the promising interventions to strengthen the immunization program now in the region? How do you see this in the context of the COVID? Of course, I mean, now COVID is becoming sort of public health imperative that, you know, everyone is committed to. So please, your perspective.
Thank you, Professor Hayam. In fact, I will respond, but before that, it's almost the same issue. I will reflect on the infodemic. You know what happened in the region. I mean, we know that the region is not prepared to deal with this kind of emergencies in general. So the public health emergency preparedness in the region is not really at the required level, and we know why, and we know all the situation. And one of the components that is lacking is the risk communication. And my colleagues in ANFNet and in WHO, they know very well, I mean, how much we had to work with the countries to try to support them to develop. I mean, some of the countries, they started really in a chaotic way. I mean, nothing was there, no communication plans, nothing. And so when they started to communicate, I mean, the COVID was everywhere, but in a very, I would say, a chaotic manner. And in the beginning, we did not think about the continuity of the other services. So this was not there for a long time, 2 to 3 months even. We did not say anything about this very important, vital issue. This is first. Second, when we usually communicate in our country, in the region, I mean, is mostly, as I said, communication is really very weak, and most of the time, you know, actually the situation in the region that the population does not really trust too much the politician and even sometimes the decision makers at country level. Unfortunately, we have a very, very important opportunity in the region that we don't use, and SAGE is very keen to activate, which is the anti-tag. Most of the attacks in the region, I mean, some of them, they're really very active, and a good number of them are having on board very trustful and very known people at the county level, physicians that can really make the difference, that can really communicate and support the EPI manager and separate program together. I mean, to get more support from decision making, but also to really have a good impact on the healthcare workers and on the population. And this has been missed. I mean, Untitled last year they convened a very important meeting of the anti-tags, and I hope that Dr. Majid is here. I think this is very important to continue this work, because this is really the issue. And again, to your question, Dr. Hayam, again, I believe that we have enough strategies, and this was actually very, very well highlighted in the evaluation of the decade of vaccine. And one of the recommendations is to say that, yes, we do have a really big number of recommendation, guidelines, strategies, etc. But how much of this is taken by the countries understood, this is the problem. So the problem remains at the country level. So, and the only way to make this happen is to work with the anti-tag. Again, back to the anti-tag, I think we need to make sure that anti-tag are moving. And back, a question from Dr. Jaidi on the same issue. I would just tell him, Dr. Jaid, you are in UNICEF, and I believe country office, and I believe that the partners at country level, UNICEF, WHO, should try their best to mobilize this resource, which is for me key to try to find at least a solution to reduce a little bit this disruption at the country level, which is the anti-tag. Thank you.
Thank you so much, Dr. Mohseni. I'm looking at the time, and we are all challenged that the time is really finished. It's over nearly. So I would like just to thank all the presenters for a very, very interesting, very informative webinar. I would like to thank the participants whom really they were very active in getting their question on board, and I'm sure that the presenter as well the organizer will handle this. Yet again, I think more will come from the different stakeholders on the, how to communicate on impact, the plan, the guidance. I'm sure as they evolve, things will move ahead. And I do thank you all for a good webinar, I would say. Thank you very much. Bye.
Thank you. Thank you. Bye-bye. Thank you. Bye-bye.